The ATLANTIS trial is a randomized, open-label, Phase 3 trial. It's an antithrombotic strategy to lower all cardiovascular and neurological ischemic and hemorrhagic events after transaortic valve implantation for aortic stenosis. TAVI is becoming used worldwide for symptomatic aortic stenosis. However, post-procedural thrombotic and bleeding events are frequent and can negatively affect short-term survival. Thrombosis formation on the implanted bioprosthetic valve can lead to potential hazards of TAVI. Recent evidence suggests that single antiplatelet therapy alone, if no need for anticoagulation, seems to be safer than that of dual antiplatelet therapy, but also for VKA therapy alone being safer than when combined with antiplatelet therapy. The net clinical benefit of apixaban in atrial fibrillation is well established in terms of its superiority to VKA, but also compared to aspirin in patients deemed not suitable for VKA therapy. So 1,510 patients were stratified according to the need for anticoagulation, and then randomized to either VKA or antiplatelet therapy in the control group, or apixaban in the experimental arm. This was a superiority study whose primary endpoint was a composite of death, MI, stroke, systemic emboli, bioprosthetic thrombus, VTE, or major bleeding. To evaluate subclinical leaflet thrombosis, a 4D CT scan was mandated between 3 to 6 months, looking for visible thrombosis on TTE or 4D scan, as well as a hemodynamic change in gradient or reduced leaflet mobility. The inclusion criteria are listed here, including patients over the age of 18, successful TAVI into a native valve, and the use of currently approved TAVI devices. The major exclusion criteria were standard exclusions based on the apixaban label, as well as recent acute coronary syndrome, stent implantation, or bleeding. Baseline characteristics were balanced between the groups and seemed to correspond with moderate to high risk TAVI patients. The average age was 81 to 82 years of age, about 47% were male, the average STS score was around 5, about 30% had permanent atrial fibrillation, about 80% had hypertension, 30% with diabetes, and 40% with congestive heart failure. The average CHADS-VAS score was just above 4. The primary intention to treat analysis demonstrates a failure to show superiority of apixaban over standard of care, with 138 events in the apixaban arm and 151 in the standard of care arm not meeting statistical significance. There was no interaction according to the need for oral anticoagulation. These are the pre-specified secondary outcomes. While there were no significant p-values for interaction, I would point out that there were numerically fewer bioprosthetic thrombotic events in the apixaban arm and fewer DVT or pulmonary embolism events in the apixaban arm. Of note, there was no difference in terms of the primary safety endpoint between the two groups, including bleeding using various definitions. In conclusion, apixaban after TAVI procedure is not superior to standard of care antithrombotic treatment in terms of net clinical benefit. However, the safety of apixaban is similar to that of current standards of care. There was a decrease in subclinical valve thrombosis, especially in the stratum of patients who were not already on anticoagulation.